Do you interact personally or professionally with someone living with Alzheimer's or a related disease? These conditions are often associated with memory loss, but significant behavioral and psychological symptoms, also called neuropsychiatric symptoms or NPS, commonly occur. These include agitation, anxiety and depression, psychosis, apathy, sleep disturbances, and wandering. These symptoms can be very hard to navigate, which is why we convened this summit of experts to equip people living with NPS, their family caregivers, and clinicians with helpful tools and resources to improve communication and care. And we hope it helps you. Hi, everybody. Good afternoon, and thank you so much for joining us today for Caring Together, Empowering Families and Health Professionals with Tools for Better Neuropsychiatric Symptoms Care. And this is a virtual summit hosted by my organization, the Alliance for Aging Research, and the National Alliance for Caregiving. I'm Sue Peshin, and I serve as the President and CEO of the Alliance for Aging Research. Today brings together family caregivers, clinicians, researchers, policy leaders, and people with lived experience, all united by the same goal, improving care and quality of life for those living with neuropsychiatric symptoms. For those of you who may not be familiar, neuropsychiatric symptoms are the symptoms of Alzheimer's and related diseases that aren't as well known or talked about as memory loss, but are still very much a part of the disease. And these symptoms consist of mood and behavioral changes that are oftentimes stigmatized and dismissed as willful behavioral problems. These symptoms can include agitation, anxiety and depression, apathy, psychosis, sleep disturbances, wandering, and more. And we're going to get into these as we go along in this webinar with more detail. They can all be very confusing and they can be worrying for the person experiencing them as well as for family caregivers. And so today we're all going to learn more about neuropsychiatric symptoms and the tools that exist that can help you navigate them and interact more with your clinician, your family's clinician, to learn about different resources and opportunities for strategies. And the key message today, really, if you take nothing else away from this webinar that we want you to know, our key message is that there are things you can do and tools that can help. So if you or a loved one is experiencing neuropsychiatric symptoms, please talk to your doctor. I want to extend a special thank you to our partners, Otsuka and Lundbeck, whose generous support makes this summit possible. And now I'm delighted to introduce and be joined today by Jason Resendez, who serves as the President and CEO of the National Alliance for Caregiving, where he leads system change efforts to value and support our nation's more than 63 million family caregivers, myself included. And Alliance for Aging Research is proud to be a member of the National Alliance for Caregiving. With that, it's my pleasure to turn it over to Jason.
Wonderful. Thank you so much, Sue, for your voice and for your leadership and turning your lived experience into action every day in partnership with the National Alliance for Caregiving. It's an honor to be here with all of you for this important conversation. As Sue mentioned, I'm President and CEO of the National Alliance for Caregiving, and we work to transform how we value the contributions of our nation's family caregivers. But before I share a few words about what we're learning from family caregivers, I want to acknowledge who's in this virtual room today. Caregivers in the trenches, clinicians working to provide better care, researchers pushing the boundaries of what's possible, and advocates fighting for change. No matter where you're coming from, your presence here matters. At the National Alliance for Caregiving, we spent nearly 3 decades studying the caregiving experience in America. And I want to share some context from our latest research that underscores why today's conversation is so critical. Our latest Caregiving in the U.S. 2025 report, released just recently in partnership with AARP, reveals that 63 million American adults are now providing care to someone with a serious illness or disability. That's nearly 1 in 4 Americans, and it represents a nearly 50% increase in just the last 10 years. And among these millions of family caregivers, more than 1 in 4 report that their care recipient is living with Alzheimer's disease, dementia, or another memory related condition. That's millions of families navigating the very symptoms we're discussing today: the agitation, the anxiety, the sleep disturbances, the wandering that Sue mentioned. And here's what our research tells us: these symptoms don't just affect the person with dementia, they ripple outward, shaping the daily lives of everyone in that caregiving circle. What strikes me most in our data is this: family caregivers are showing up day after day, often without the tools or training they need. More than half of all family caregivers are performing complex medical and nursing tasks. Things like managing medications, monitoring vital signs, managing feeding tubes, you name it. Yet only about 1 in 5 has received any formal training to do so. When it comes to helping with personal care and daily activities, that number drops even further to just 11% who have received training. Think about that for a moment. We're asking families to provide increasingly complex care, often for years at a time. This is particularly true when it comes to dementia related conditions. Our research shows that 30% of family caregivers have been in their role for 5 years or longer, and we're sending them in to this care without a playbook. And the toll that it takes is real. Nearly two-thirds of family caregivers report moderate to high emotional stress. Almost half experience physical strain. And increasingly, family caregivers tell us that they feel alone. That number has risen since our last study, with nearly 1 in 4 saying they feel isolated in their family caregiver role. But here's what I want you to hold on to as we move through today's program: caregivers also find meaning in this work. Half of all family caregivers tell us that their role gives them a deep sense of purpose. That's not denial, that's resilience. That's love showing up even when it's hard. And that's precisely why gatherings like this one matters. Because when we equip families with knowledge, when we give clinicians better frameworks, and when we create space for honest conversations about what neuropsychiatric symptoms actually look like and what can help, we're not just managing a disease. We're honoring the humanity of everyone involved in care. The key message you'll hear today: that there are many things that you can do, tools that you can help, isn't just hopeful rhetoric. It's backed by evidence, and it's what caregivers are asking for. In our research, caregivers consistently tell us that they want more information about managing challenging behaviors, keeping their loved ones safe at home, and navigating the emotional weight of this journey. So, as we hear from our incredible panelists, I encourage you to listen not just as professionals or advocates, but perhaps as someone who has been in these shoes or who might be one day, because caregiving touches nearly all of us eventually. So, thank you again to Sue and the Alliance for Aging Research for your leadership in driving action on these issues. We are so lucky to have you moving the care movement forward with us through conversations like today. Thank you.
Jason, thank you. I loved your remarks as always. You just know how to hit the points that people think about. And this is going to stick with me is love showing up even when it's hard, right? Thank you for that.
Absolutely. Thank you.
So, before I introduce today's exceptional speakers, I have a few housekeeping items. First, the webinar is going to be recorded and will be accessible on the Alliance's website after the event, which is agingresearch.org/NPS, like neuropsychiatric symptoms. So agingresearch.org/NPS. And everybody who's on here and those who registered, you'll get a link to that. But if you'd like to spread the word and share with friends, we would love it. So second, we're going to have a live question and answer session at the end of each panel. So we just really encourage all of you to use the chat function at the bottom of your screen to submit questions for our panelists. And feel free to ding again if for some reason we didn't get to your question, but we'll try to get to everyone. We're also going to be doing some poll questions, and we'd love for everybody to participate. The answers are going to be completely anonymous, and it's a fun way to learn about other folks on the webinar and for us to learn about you, and to also just have a shared experience together. So here's our first poll. Okay. Before I introduce our first panel, well, you just saw those questions appear on your screen and you hopefully took a moment to respond. So for our first panel, Expanding Understanding of NPS, Tools, Perspectives, and New Approaches, we are thrilled to be joined by 5 phenomenal speakers who will shed light on tools and resources available for providers, caregivers, and patients who are working with or experiencing neuropsychiatric symptoms, people living with neuropsychiatric symptoms. All of our speakers today have tremendous biographies, and I don't have time to do all of their bios justice, but we have shared the full copies on the Zoom registration link, so I'm going to keep it brief and get to their presentations. Our first speaker is Dr. Carolyn Clevenger, a nationally recognized educational leader in advanced practice nursing and in geriatrics. Oh, here's the results, which are very cool to see. A lot of people somewhat confident. Let's see. And many caregivers. Welcome. Good to see everybody. So going back to Dr. Carolyn Clevenger, she's the founder and director of the Comprehensive Dementia Care Model, the Integrated Memory Care Clinic Director at Emory School of Nursing, and will soon be starting a new role as the founding dean at the University of Georgia School of Nursing. Welcome, Dr. Clevenger, for your remarks and for your exceptional work. Thanks for being here.
Thanks for having me. I'm glad to be with you all today. There are several other amazing presenters who will follow me, and I'll begin by walking folks through what we mean by this neuropsychiatric symptom umbrella, and then I'll introduce a tool with a couple of other words of advice. That is, by the way, the first time I've seen a slide with my name next to Dean, so thanks for that, guys. We can go to my first slide from here. Great. So, as I mentioned, we're going to talk about this neuropsychiatric symptoms in dementia, and many times you'll see this abbreviated as NPS. But let's go to the next slide and talk about what we mean by neuropsychiatric symptoms. First, I think it's important to begin by understanding that when we say the syndrome of dementia, which has a cluster of symptoms, they go far beyond simply memory loss. And for folks whose dementia is not due to Alzheimer's disease because they're living with Lewy body disease, frontotemporal degeneration, and so forth, memory loss may not be the most prominent symptom that they're living with and experiencing and that others around them experience. So these other symptoms are here on the left. They include things like apathy, just that loss of initiative, not enjoying or finding pleasure from things that used to give you quite a bit of pleasure or really brought joy to your life. It can look very similar to, but is different than depression or depressive symptoms. Depression in older adults in particular, and people living with dementia may or may not look just like mood disorder where someone is sort of sad or tearful. It may also show up as a lack of appetite or disruption in sleep. Aggression or agitation. We'll talk about agitation a little bit more when I introduce the tool that I'll share with you. But agitation, we now understand it's not this little global word that we've thrown around for a long time in the care of people living with dementia. What we mean by agitation is this excessive activity or restlessness, pacing, verbal aggression or verbally aggressive comments, and then physical aggression. All of that falls under that umbrella of agitation as we now understand it. Anxiety, or so the experience of anxiety, the appearance of anxiety, and then sleep disorders or disturbances in and of themselves may be driven by changes that are occurring in the brain structure and in the way that the cells communicate with one another. And sleep disturbances may be outward symptom of things like depressive symptoms or anxiety as well. And so these are very common, almost universal for people who are living with dementia to experience one of these at some point in this journey. And in fact, they may be the first indicator that there are changes in the brain that are occurring before we begin to see or notice some of the cognitive changes in processing and understanding and abstract reasoning and thought. We also know, though, that when someone is experiencing neuropsychiatric symptoms, it can affect the progression of other symptoms, which we would say looks like a more rapid deterioration or decline in their disease progression. Makes it very challenging in terms of both receiving care and being able to give care to someone who's experiencing neuropsychiatric symptoms. Hopefully, we understand that this is its own medical symptom. It distinctly requires treatment different than the way we treat cognitive symptoms. And also, we know this is manifesting from the disease, not the person that we care about, but it can make it very challenging to be their main caregiver. Caregiving, as we've heard in dementia, is already, it's a 24/7 job. It's on your mind all of the time. It's physically intensive. And when this person is also experiencing some of these symptoms that we've just discussed on the left here, can be even more distressing, adds strain or caregiver burden. And in instances in which that's the case, that may lead to an earlier than anticipated or than desired institutionalization. So that is placement in residential care, whether that's assisted living, memory care, or skilled nursing. And we know it increases the mortality risk. So people who are experiencing these symptoms do have a shorter lifespan. So you can see why it's such an important topic for us to focus on today, and that we want to certainly understand that this is a symptom distinctly separate from cognitive symptoms. It is a symptom that requires its own treatment plan so that we can have more empathy and also opportunities to intervene, and ideally to recognize something early so that we can manage it earlier. Next slide, please. So I want to introduce you to a tool is relatively new to empower that earlier recognition of specifically agitation. So this is the Agitation in Alzheimer's Screener for Caregivers, or the ASK. The ASK is both built on input from family caregivers and experts to quickly identify the symptoms specifically for agitation so that we can have these conversations earlier, because many times your clinician does not know they're occurring. They probably are not occurring during an office visit, especially the short office visits we often have in primary care. Even in longer visits, people have a very different sort of way of presenting and showing up in a medical encounter. But it does help to identify the specific behaviors. So we wouldn't say, like, is your person agitated, right? We would say, have you observed these behaviors? The rocking, pacing, verbal aggression, resistance to care, and destructive actions. It's a brief tool. We know during an encounter, as you're doing those maybe e-check-ins or the pre-visit questionnaires, we want to do this briefly because the idea is not to necessarily diagnose agitation. It is to kickstart a conversation about what kinds of symptoms you're seeing. And then we can get, and your clinician and you can get into a deeper conversation about exactly what's happening, what seems to make it better, what makes it worse. The idea overall is to reduce the distress that comes along with experiencing this symptom, especially if it escalates and no one is even aware that the symptom is being experienced. So we're trying to reduce distress, get that timely intervention, ultimately to improve patient outcomes. Next slide, and we can take a look at this tool so you can see the snapshot of what it looks like in action. Here it is, the Agitation and Alzheimer's Screener for Caregivers, or the ASK, and you can see the questions that we ask specifically to recognize whether or not these have been present and that they are a change, that this is not sort of something that the person has all of the time. This is unique to what's happening now, and that it negatively affects this person's ability to receive care, which speaks to then the care that we need to provide as support and the care that this person may need going forward. You can find this relatively easily. Not all clinicians, many clinicians may not use it. I will say, if you are a family caregiver, and I saw there are many of those who are present on today's webinar, then you also can pull this off as a PDF and complete it and hand it to a clinician or their staff so that you can hopefully have a better conversation during the visit. And the next slide, just a couple of words of advice as I transition to our other panelists. So this is one piece of a larger toolkit, but we know if you are someone who is an operator, you were running an organization, it can be helpful to offer these sort of screeners. I also learned a long time ago, early in my nursing education role, in that asking the question is also an opportunity to educate. And so the fact that we've asked about these symptoms may also help our caregivers identify that this is part of the dementia syndrome and an opportunity to intervene. So let's make sure, as if you are a service provider, that we are offering resources to our families in the care of people living with dementia in a comprehensive dementia care model. You are not only managing your patient, you are managing their support system, which is often a family caregiver. And for our healthcare professionals, this is one tool, the ask. Obviously, we know we have others like the Neuropsychiatric Inventory Questionnaire or the DICE tool, but we have tools available to us. We just want to make sure that you are using a tool in some standard and reliable way. And you may imagine that at a practice like mine, even an incredible team, this is beyond just your single clinician. Remember, you've got your front office staff, you've got the person who's triaging, and so many services in our communities to support our families to maintain the support that they need doing this 24/7 job of family caregiving. One last slide, and this is specifically to my colleagues who are healthcare professionals who are on today's call, which is that I implore you to use a screening tool, a validated and reliable tool to kickstart and have these conversations so that we identify symptoms early and maybe provide you some guidance in how you tailor their care plan around that. That if you find it challenging to do this within the visit, that you create a pathway, a front door for our family caregivers to be able to share their concerns, whether that's with the patient present or another pathway, whether that's a note, it's a call, it's a caregiver only visit. And that you can think about how we integrate not only these symptoms, but other neuropsychiatric symptoms into your dementia care pathway, which of course requires not only your expertise, but staff training. And there are reimbursement opportunities available more so than ever for some of these supports services. And to make sure that everyone in our team understands and has that empathetic communication to advocate for our patients. Thanks, guys.
All right, soon to be Dean Clevenger. Thank you so much for your remarks today and for your exceptional work. And, as we mentioned towards the beginning, at agingresearch.org/NPS, we're going to have these resources listed. We're also putting together a very short paper, a summary, that will have all the resources easily available that you can send around to others as well. So our next speaker today is Bonnie Waddles. She serves as Executive Director of Hilarity for Charity, also HFC. She's leading the organization into its next phase of growth, providing care and support for families impacted by Alzheimer's disease and activating the next generation of Alzheimer's advocates. Bonnie holds a BA from Hamilton College and an MBA from Columbia Business School, and her work honors her grandmother, Sadie, who lived with dementia. Welcome. Thanks so much for being here, Bonnie.
Thank you so much, Sue. I'm delighted to be here, and thank you to the Alliance and to Caregiver Action Network for inviting me to share more about Hilarity for Charity and the resources that we provide to support caregivers. Next slide, please. Next slide. So as many of you know, Hilarity for Charity was founded by celebrities Seth Rogen and Lauren Miller Rogen after Lauren's mom, Adele, was diagnosed with early onset Alzheimer's at just the age of 54. They were young, falling in love, and obviously this was very challenging for the family, but they wanted to turn their grief into action and create a community for the younger generation and reframe Alzheimer's as a public health crisis, not just an older person's disease. So today, HFC is a national organization supporting families at all through the Alzheimer's journey and dementia journey. We have a suite of caregiver programs, including in-home respite care, support groups, one-to-one supportive services, and wellness programs. And we also focus on prevention. I'm not going to talk about it today, but I just wanted to mention that because 45% cases of dementia may be preventable, we strive to let young people know that their brains are something that they can take care of. We have evidence-based curriculum called HFC Universe and a national chapter movement called the Youth Movement Against Alzheimer's, engaging thousands of people, young people across the country to build brain healthy habits early in life. And finally, we leverage our celebrity platform, events, social media, press, storytelling, including our documentary film, Taking Care, to elevate awareness and change the narrative around caregiving and Alzheimer's and dementia. Next slide. Some stats here. So we do care for caregivers. We award roughly 30,000 hours of free in-home respite care. We serve about 500 caregivers in our ongoing weekly support groups. We are offering now CEU credits through our annual event CareCon, and we also have one-to-one services, including care navigation and financial coaching. Next slide, please. So as we all know, our respite program is really one of the hallmark offerings of Hilarity for Charity. From the beginning, Seth and Lauren really wanted to provide caregivers with immediate relief, time to rest and recharge. Families can apply year-round. Our grant applications are reviewed monthly. One in-home grant provides 100 hours of professional care to be used over 6 months. We recently expanded the options to include adult day respite grants. That enables us to reach even more families and provide preferred options for care. And the adult day grants cover 24 days of care. Applicants, in order to qualify, applicants need a professional diagnosis, and they must demonstrate financial and emotional hardship. And for adult day, we screen for mobility, if they can feed themselves, and if they can use the restroom on their own. Next slide, please. So our measurement and impact evaluation work ensures that our programs stay responsive to caregiver needs. And as you can see, the data is clear. Not surprisingly, respite care really makes a difference. 93% say the care grant helped them manage their stress. 75 say it helped them attend to their own medical or financial needs. And we just see reports of improved self-care, social connectedness, and ability to manage daily tasks and family responsibilities. Next slide. Our support group program, another hallmark program of HFC, based in our founders' experiencing navigating care at a young age. The support groups are free, virtual, and tailored. They are all run by credentialed facilitators, and they're tailored for whether you're an adult child, a younger caregiver, caring for a spouse, BIPOC caregivers, and more. Next slide. We operate 45 groups serving 500 participants, and remarkably, we've had 0 facilitator turnover since the beginning of the program. Next slide. And in terms of the impact, caregivers are telling us that support groups dramatically improve their own well-being and their ability to provide care. 84% maintain a more positive outlook on caregiving. 86% feel more emotionally prepared to provide care. And additional data supports that support groups help them provide better quality care, being more patient, more present, and better informed about dementia and the caregiving journey. Next slide. We also have a community lounge series. These can be found on our website. We do about 4 to 6 per month. Topics range from helping to manage the activities of daily living, as well as financial planning, as well as self-care, such as meditation or yoga. And all of these are free and accessible. Next slide. And I'm very excited to talk to you today about HFC's Caregiver Road Trip. This is one of our newest tools. It's an interactive digital guide for younger dementia caregivers, although definitely useful for caregivers of all ages. We've had terrific responses with over 28,000 views so far, and it covers key topics including types of dementia, getting a diagnosis, building a support network, planning ahead, and definitely touches on managing behavior and neuropsychiatric symptoms, legal and financial prep, hospice, palliative care, grief, and more. We like to pride ourselves on providing content that is practical, digestible, and relatable in terms of tone. So there's a link here in this. I'll drop it in the chat later, but feel free to explore the caregiver guide. And in our next slide, we have a sizzle, so you can see more about it.
Hello there, caring person.
Welcome aboard HFC's Caregiver Road Trip.
This is not a typical road trip.
Let's be honest, you probably didn't even mean to take it. You're not entirely sure where you're headed, and you have no idea how long it's going to take.
We hope this guide helps you move from what the is happening to an adventurous outlook of all this trip can be.
One way the dementia journey is true to a typical road trip is that there is no one route.
Consider each section an on-ramp. You don't have to take every exit.
You don't even have to start from the beginning. The key is to have a plan, mostly.
While also learning to stay in the moment and take the journey day by day.
This guide is designed specifically for care partners under 50, but age is just a number, right? So hop in no matter how old you are.
There's plenty along the way that's relevant to just anyone who cares.
Thank you. And so we've had very positive feedback. 100% of users would recommend the guide. 87% say that it helps them be prepared for the future. And we love to hear back. We're hearing from colleagues. People are saying that the information is vital, relevant, relatable, and has a tone that resonates with their audience. Next slide. Why don't we skip to the CareCon slide since we're running out of time? I finally just wanted to share with everybody that our 6th annual CareCon Virtual Caregiver Summit will be happening on February 25th. We would certainly love for all of you to join, and that is free for caregivers and professional caregivers to attend, so we hope we see you then. Thank you so much.
Bonnie, that was terrific. Thank you. Thank you for your leadership, and thanks to Seth and Lauren. And I look forward to attending the summit. I'm going to put that on my calendar. So that brings us to our next speaker, Daniel Pace, who serves as Chief Strategy Officer and Vice President of Education at the American Academy of Physicians. At AAPA, Daniel is responsible for developing strategic partnerships with a range of healthcare organizations and stakeholders, and he brings a collaborative approach and commitment to partnering with purpose. With 2 decades of experience, Daniel is passionate about the PA profession as a solution to many of the workforce challenges facing healthcare today. Welcome, Daniel, and thank you so much for being here.
Thank you, Sue, and thank you all for having me today. I'm excited to be able to share with you some resources that we have put together at the American Academy of Physician Associates that can, I think, both be helpful for, of course, PAs and other clinicians, but also potentially for care partners as well and caregivers. And after seeing Bonnie's presentation, I know now we need to add the Hilarity for Charity road trip as a great care partner resource as well. So you can go to the next slide. All right, quick overview about AAPA. So AAPA is the American Academy of Physician Associates. We represent the more than 190,000 PAs that are practicing across all medical and surgical specialties in all 50 states, the District of Columbia, the U.S. territories, of course, the uniformed services, and there is an international contingent of the PA profession that's budding as well around the country. So PAs, really have a critical opportunity to impact the care across the spectrum, but particularly as frontline providers practicing in every medical specialty and setting, they're very likely to encounter and treat patients that have dementia and are experiencing some of these neuropsychiatric symptoms. As the number of patients living with dementia increases, and of course the PA profession is one of the fastest growing professions in healthcare, we see a real opportunity here to provide resources and have curated them into a toolkit here that I'll share a little bit more about today to really help PAs and other clinicians recognize, diagnose, and treat patients that are exhibiting those NPS. Next slide. All right, this is going to be a little bit small on your screen, but just wanted to give you a quick overview of what we've included in this this NPS toolkit. So this lives within the AAPA website in a section that we have recently launched called a clinical resource library. We heard from PAs that they needed concise, practical resources that would help them with a range of diseases and conditions. So we have been working with partners to develop toolkits and other resources, organizing them in different areas of clinical focus, some aligned with priority areas that we see as areas that PAs have a real opportunity to have an impact. So in this case, we have curated some information around kind of an overview of the impact of Alzheimer's disease, a quick summary of general risks and consequences of neuropsychiatric symptoms. And then, of course, we found that one of the most important things that clinicians wanted to see was very high-level, quick FAQs related to NPS. So we curated a list of FAQs that I'll give a little bit of a summary of here in a bit. And then we found that there was a need to generate some new content specifically for clinicians on some hot topics that when we worked with our planning committee, we found that these were kind of topics of conversations, areas that continue to come up over and over, and they wanted a quick reference that sort of distilled some of the latest evidence and literature and would help them facilitate those conversations and course of care with their patients. We've also pulled together a lot of the existing resources from some of the other great organizations in this space and made them available in an additional resources area, including some of the screening tools, such as the Ask that Dr. Clevenger shared earlier, as well as caregiver resources and other resources that could be helpful as well there. Just a quick moment to highlight, we did have 2 PA expert faculty that sort of steered our work in this space. We felt it was important to have a clinician perspective that both represented sort of the specialty side of care. So we had Jordan Mast, who's a practicing PA in neurology, provide that expertise. And then we also wanted to make sure that, this was really relevant for those frontline providers, particularly those that maybe have less access to resources, maybe not in academic medical centers, that sort of thing. So we partnered with PA Amy Klingler, who has been on our editorial board for our journal for many years and is practicing rural primary care in Idaho. So she provided a really unique perspective for us on kind of, how to approach some of these things in a patient practice that is seeing a greater number of course, these symptoms and is looking for tools and resources that maybe doesn't have as much available from her system. If you can go to the next slide. All right, this is just a quick snapshot of the FAQs on neuropsychiatric symptoms that we provided. Again, in talking with Amy and Jordan, they really emphasized that we need to kind of just bring some of the key concepts right to the fore. So right within the toolkit, we've given a highlight of some of these expandable FAQs. I won't read them all here, but just covering what are the NPS of Alzheimer's and related dementias. How common are they? When do they appear? Driving continues to come up, so we have an FAQ on driving. And many of these FAQs lead to more detailed articles that we also developed as well. Go to the next slide. All right, so we found that there were some topics that warranted a little bit of a deeper dive. So we developed these, worked with a medical writer, our faculty and planning committee worked with a medical writer to develop these 5 high-yield articles. And we found that in our sort of research needs assessment work with PAs, they really want information that is, not always the long-form sort of scientific articles. They really need sort of the bulleted information, the top sort of key points that they need to know, fully referenced, of course, but in a really concise format that they can digest quickly, reference as needed. So we developed these 5 articles, one around sort of just getting to know your patient. So what types of questions are most useful? How do you approach those sorts of questions and conversation with patients and their care partners? We also had an article on non-pharmacologic interventions, which our faculty recommended is, of course, the first step here to try to address some of these symptoms. And then had a pharmacologic approaches article as well. Again, driving seems to be the most emotionally charged conversation that takes place in this space. So our faculty were insistent that we provide kind of a more detailed resource around Alzheimer's disease and driving. And then we have a number of PAs. It's probably the second, maybe second, third largest specialty within the profession are in the emergency department or in urgent care settings. So we wanted to provide some specific guidance and tips and considerations for those clinicians that maybe are encountering patients that are exhibiting these NPS in different settings as well. So those were a set of articles, again, very concise, bulleted information, fully referenced, that again are intended for clinicians, but probably would be quite useful for caregivers and care partners as well. Next slide, please. Okay, and then just a quick update or quick overview on how this has been received by our audience. So we have primarily been marketing this toolkit to PAs via some of our existing channels. We have, of course, newsletters, e-blasts, the website itself, which I mentioned. We've done a lot of social media, and we've seen pretty good uptake and utilization of the toolkit. We had about 1,900 views in the first 9 months since the toolkit was launched. You can see that translated into about 1,300 or so clicks. And I got a summary here of kind of which topics were they clicking on the most, but it's really those top line kind of FAQs that I shared earlier. So what are those symptoms? When do they appear? How common are they? What are the diagnostic criteria? How do you screen? So there's really sort of bread and butter concepts that PAs and other clinicians and probably other stakeholders benefit from being familiar with. We've gotten a large number of impressions around the social media posts that have promoted the toolkit, with a little over 10,000 impressions there and almost 200 clicks. And always interesting to see kind of where the traffic is coming from. While we're out there proactively marketing it, the biggest traffic driver for us has actually been Google. So I think this goes to show that there are individual clinicians and caregivers that are searching for this information, and we're glad to hear finding it via just general search pathways that way as well. And I think that's all I've got. Thank you for the opportunity to share. And we'll drop the link to the toolkit into the chat as well.
Awesome. Thank you so much, Daniel. The information on Google, I think, is really fascinating. And I think it's great that just all the groups that are participating today have created accessible resources. There's a lot out there that I think can be intimidating or hard to understand or just not easily relatable. And this is just amazing, everything that you've done. So thank you for your work and your commitment. It's great to have you here today. So our next speaker is Jen Pettis, Director of Strategic Alliances at the Gerontological Society of America, a member of the Alzheimer's Association of Northeastern New York Board of Directors, and active community educator for the Alzheimer's Association. Ms. Pettis was recognized by the National Hartford Center of Gerontological Nursing Excellence as a distinguished educator in gerontological nursing, and she also received Sigma's Amy J. Berman Geriatric Nursing Leadership Award. Welcome, Jen, and thank you so much for being here with us today.
Thanks so much for having me, Sue. I appreciate the opportunity to share one of my favorite resources, and that's the GSA KAER Toolkit for Brain Health. This toolkit, you can go ahead to the next slide. The toolkit is a completely free online interactive toolkit that is really a living, breathing thing that we're continually updating with, informed by an expert panel. And I invite you to use the QR code, or you can find it at carebrain.org. And on the next slide, we just highlight highlight the framework. So the CARE framework started back in 2013 with a request from CMS, who came to GSA and said, folks really aren't using that annual wellness visit. What could you do to help? And GSA pulled together a work group, and in 2015, presented a report and recommendations. And within that was this framework, this 4-step framework to kickstart a brain health conversation, to assess for cognitive impairment, to evaluate for dementia, and then to refer to community resources. And that referred to community resources. Think back to that time of 2015. We didn't have disease-modifying treatments yet, and people often asked that question, why bother get an early diagnosis? What are you going to do anyway? So this referring to community supports and services was all about supporting people where they are to help them maintain their independence and in the community setting in which they wish to live. And on the next slide, it just highlights several features of that toolkit. It is a fully online resource. So the first toolkit was born in 2017 and then updated with a full literature search in 2020. And then in 2024, after another updated literature search, we launched the fully online resource. It is user-friendly from a navigation standpoint. And there's 4 main sections that align with each of those letters, the KAER. Each of our sections has key takeaways, and I'll share some of those with you in just a moment. We really increased a focus in this version of the toolkit on certainly on culturally competent practice, but also looking at brain health promotion and the importance that folks can do to reduce their risk related to for dementia and related concerns. And we do incorporate the best of the best tools. So I often say that the things that are included in this toolkit, some of them are GSA resources, but most of them are resources that are evidence-based that others have put forward. And we're very blessed to work with a wonderful panel of experts that help guide our ongoing updates and enhancements to the toolkit. And on the next slide, I'll introduce you to the first section, and that is the Kickstart, to kickstart the brain health conversation. In this section is all about raising the topic of brain health, educating people about their modifiable risk strategies and or risk factors and strategies to support brain health, asking individuals about their memory and cognition, listening for concerns from our patients, but also their families, and then addressing sensory loss, using effective communication, and really supporting primary care teams to have effective conversations with individuals about their brain health. We also address sensory loss in this section and give some ideas around that, and then really stress throughout the toolkit that addressing impaired cognition and looking for impaired cognition really is a team sport, and Dr. Clevenger alluded to that in her remarks. And then in this next several slides, I just want to give you a little walk through what a user might look, what they might see in the CARE toolkit. So if they were to click on the Kickstart section, they would click there, and that would move them right to the next picture that you'll see on the next slide, where there's several options, kind of a menu in each setting. So this, they're going to click on Discuss Brain Health, and then they'll move through the next slide where they'll see one option for some interactivity is to read about a practice pearl from one of our experts. So if they were to click on this button about kickstarting a brain health conversation, they'd read the advice from Dr. Sue Borson. That's one of our practice pearls. So that's just an example of some of the interactivity. And we'll move on to the next letter, which is assess for cognitive impairment, for the A. Excuse me. The assess section is all about detecting cognitive impairment, and we stress the importance to use a validated brief cognitive test to assess for cognitive impairment. Again, I'll mirror what Dr. Clevenger said. Just pick something. We never say what the right one is, but we offer lots of options and kind of lots of insights into which one of these tools may have advantages or disadvantages, and hopefully provide provider teams with options to and just additional information to make the best choice for their practice. We also talk in this section and provide resources about gathering information from informants and certainly from the individual about subjective cognitive decline. So the assess section, the A section, is all about determining whether that individual should receive a diagnostic evaluation. And then on the next slide for the E, the evaluate for dementia. Here we provide teams, caregiver teams, with tools that help them clearly explain the goals of the diagnostic evaluation, the diagnostic process, and to implement that diagnostic process or refer to a specialist. And then help give them resources to appropriately document and disclose that diagnosis. And then that brings us to the final letter, which is refer for community resources. And this is all about referring to providers, to resources and services, and supporting continuous education and giving individuals and their families the opportunity to refer to clinical trials. And just before I close my remarks, I want to mention a couple of GSA's agitation and Alzheimer's dementia resources. So on the next slide, we highlight a decision tree for healthcare providers. Excuse me. This is a decision tree that allows provider teams to really take a step-by-step approach to identifying in managing agitation and Alzheimer's, and certainly a useful tool for neuropsychiatric symptoms in general. In the next slide, I highlight our agitation and Alzheimer's publication that we call Insights and Implications. And this is a useful tool, the useful report that includes some case studies, kind of some case-based learning, and there's an infographic that accompanies that. And then my final slide, I just want to offer my sincere thanks for the opportunity to be part of this panel today, and just encourage you to be in touch with me if I can answer any questions, and to check out our free evidence-based resources that are available online. Thank you so much.
My trigger finger with the camera. All right. Jen, that was amazing. Thank you. I love this program. I recommend everybody check it out. It's on the screen here. We'll include it on our website. We'll include it in the summary. Our final speaker on this panel is Monica Moreno, who is Senior Director of Dementia Care Navigation at the Alzheimer's Association, where she manages operations for the Dementia Care Navigation Service powered by Ripple and the Alzheimer's Association. She is also co-author of a chapter in Evidence-Based Protocols for Managing Wandering Behavior, which was named Book of the Year by the American Journal of Nursing. Welcome, Monica, and thanks so much for joining us today.
Thank you, Sue. Hi, everyone. I've been with the Alzheimer's Association for a little over 21 years. You go to the next slide, please. And I remember saying a couple years ago, I'm like, how is it that the experience of our families after getting a diagnosis has not changed in all this time? In my conversations with families, we have heard over and over how after receiving a diagnosis, they were told to go home, put their affairs in order, and really left with very little guidance on what to do next, what to expect, and how to plan for the future. For many families, the caregiver or care partner goes to the internet, Googles the diagnosis, and there they become overwhelmed with the amount of information, and they don't know who the trusted resource is. To be fair to providers and their care teams, they want to be able to support their patients who are living with dementia and caregivers, but they may not have the time or may not even know what resources are available in the community to be able to share those with the families that they're working with. Now, if you can imagine the impact of having access to a dementia care navigator, what that could do for families if they were referred to a dementia care navigation service right after diagnosis. Next slide, please. So I had the opportunity to talk to one of our former early stage advisors, Tony and Corey, his wife, and ask them the question, looking back at your experience, what difference do you think having access to a dementia care navigator would have had on your experience? Let's listen to what they had to say.
So if we would have had a navigator through this process of diagnosis, it would have taken a huge weight off my shoulders, because based on our area, as far as geography, we don't have care that is specified for his needs. And so we have to go outside of the area, trying to find people, trying to get into the office is very difficult. And had we had that opportunity, it would have made the last 2 years so much easier than what we've had to deal with. It's a heavy load for one person to try and navigate it. And I have the ability to be able to navigate that. I don't have a different language. I don't have those kinds of issues that some people do. So that would have been a huge opportunity for us.
I agree. I think a navigator would have changed the whole trajectory on a lot of things, on how we had family and friends exposed to the disease, on how I felt. But I think looking at the future now and what that looks like, I remember sitting there and saying, it felt like it was just us, and we were going to different medical systems and seeing different doctors, and Corey kept saying, "Guy, isn't there just one person that we can have?" We got to one place and we thought within that system there would be somewhat of a navigator, but really it was more of a scheduler. And what I needed was to know that my security was getting the help that she needed. There are many times through this process people will say, "Tony, what do you need? Take care of her. Tony, what can I do for you? Take care of her. Because she's taking care of me, you take care of her, and I'll be just fine." When I show up and I see how angry she is, or I see she's crying at night because we're not getting what we need to get, that's hard on me. So then my system, my symptoms present even more, or I'll have a worse day, or I won't be able to function correctly. So having that navigator seems almost like a third base coach or a representative that will advocate for the team.
So now, while Tony and Corey's story is unfortunately all too common, there is change that's happening that's available to families today. Next slide, please. The Centers for Medicare and Medicaid actually announced about 2 years ago that they were going to be launching a new program called Guiding an Improved Dementia Experience. It's called GUIDE for short. And this program is available to anyone who's been diagnosed with Alzheimer's or related dementia and has traditional Medicare AB, so that red, white, and blue card that you have as your health insurance. The GUIDE model actually provides these families with a litany, these 9 elements that you see on the left-hand side, and a dedicated care navigator who will work with you, support you throughout your entire journey. Families will get access to 24/7 support services. As you've heard today, Alzheimer's and dementia is complex, and it's not a 9 to 5 caregiving role. There's things that happen in the middle of the night. Families will be able to call the support service of their GUIDE participant and be able to get that education and support services directly through them. There's care coordination. There's person-centered care plans to really understand what is happening within your family, what are some gaps that exist, and what are some services that are needed. And that navigator is going to be able to identify those resources and put those into place for you. You'll be able to get access to a clinical team, sometimes a nurse practitioner, a licensed social worker. We know that comorbidities are very big for individuals living with dementia. They may have diabetes, heart issues, and there's a lot of medications and a lot of different specialists that are providing care to the individual living with dementia. But there's also a lot of side effects that can happen, especially if people aren't talking to one another. This navigation service will be able to ensure that everyone is on the same page and all the specialists and the primary care doctor understands what's happening and what interactions may be occurring, and they're all working together in the best interest of the person living with dementia and their caregiver. There's also a respite benefit up to $2,500 a year for the family. I know some of you may say, well, that's not a lot of money, but I'll tell you that it is something. It's better than what families are getting today, which is really nothing. Now, all of these services, as I said, are for those who are eligible under traditional Medicare AB. You must have a diagnosis of dementia, the person living with dementia cannot be living in a long-term nursing community as their primary residence, or be enrolled under hospice that's being paid for under Medicare or in a PACE program. If you are on Medicare Advantage, this program, you would not be eligible for that. I do like to tell families it's a start, right? So I know that while we want everyone to get access to this type of navigation service, we're just thrilled at the Alzheimer's Association that CMS Medicare has decided to pilot this for the next 8 years, to evaluate it and to be able to offer it at least to those with traditional Medicare. And we know after those 8 years, if this program is successful and we see great impact, once Medicare approves things, we will fight for other payers to be able to provide this service as well. The goals of the GUIDE program are really threefold. One is to keep the person living with dementia at home and in community and safe for as long as possible. This program is very unique in that it addresses the needs of the caregiver. So many resources in the community just focus on the individual living with dementia. But this program recognizes the very important role that caregivers have in providing that support, especially as dementia continues to progress and more of those caregiving responsibilities fall on the caregiver. So caregiver stress and reducing that stress is critically important. And then third is really to reduce costs to Medicare and Medicaid by being able to keep people home and helping to address that caregiver stress. Next slide, please. Now, the Alzheimer's Association, in addition to providing all GUIDE participants across the country with access to our education and support services that they can share with their families, the association also wanted to add to our portfolio of programs and services a navigation service. And so we're collaborating with a company called Ripple Care. They actually have been delivering dementia care navigation for a while, and it meets the GUIDE requirements. So it's still able to deliver on all of those 9 elements that I showed you in the previous slide. Again, the navigation service will provide you with that dedicated care navigator. It's really important to note that this service does not replace the care that you're getting from the primary care doctor or specialist. It really is an added layer of dementia support that works in collaboration with the primary care doctor and all of the specialists. And our guide model is really virtual. We recognize that there's a lot of families who are not close to health systems in the big urban areas. And so telehealth really allows us to reach families where they are without having to drive 2 or 3 hours to get to a health system or a clinic to be able to get this navigation service. And so telehealth has really played a big role in being able to reach more people. Our service in particular is available in 5 states. I left Texas, Illinois, Washington, and Florida, as well as Missouri. And then we're planning to grow in the next couple years as well. Now, today, there are about 327 guide participants across the country that CMS has actually approved to deliver this service. And I'll talk a little bit more about where you can go to find a guide participant in your community. Next slide, please. So this is just quickly an overview of the impact of navigation services, in particular ours. You'll see there's been a reduction in emergency department visits, hospitalizations, increased caregiver stress or reduced caregiver stress, or it stayed the same, and increase in caregiver confidence. Next slide. I know you probably have a lot of questions around this program, but if you go to alz.org/guide, we have all of the information around the guide program, and there's actually a link there that will take you to CMS's website where you can find a guide participant in your community. Thank you.
Monica, thank you so much. And it's always a pleasure to partner with you. This was an excellent, just substantive filled session from all of you. We are running a couple of minutes behind, so I'm going to go into panel 2. We may end up asking panel 1 to put your cameras on a little bit later in the program, so please be sure to hang out with us. But for now, I'm going to go on to panel 2 because we've been answering a couple of questions along the way here, and we'll make up a little time. So for our next panel, we're joined by 3 incredible speakers who are going to share their personal and clinical perspectives as a patient, a provider, and as a caregiver. And as I introduce our speakers, you should see the next 2 poll questions. So go ahead and share your answer to the poll on your screen. Our first speaker is Jim Taylor, President and CEO of Voices of Alzheimer's and friend of the Alliance. Okay. Hold on 1 second. My goodness. Just wait 1 sec. Jim's wife, Jerry, was diagnosed in 2012 with mild cognitive impairment that was later diagnosed as Alzheimer's disease. Jerry was a participant in the aducanumab clinical trial, and later the couple became prominent patient advocates across the world, addressing stigma, choosing to live well with dementia, and promoting clinical trial participation. The couple, Jim and Jerry, were also awarded the Alliance's Perennial Hero Award for their amazing Alzheimer's advocacy. Jim is an FDA-appointed Alzheimer's patient advocate and was appointed by Governor Cuomo as a patient advocate on the New York State Alzheimer's Council. Jerry died on August 4th, 2024, and Jim continues the important work that he does in her memory. Jim, thank you so much for joining us, and thank you for being who you are.
Thank you, Sue. Thank you, Sue. It's a real honor and pleasure to be here today. And you can take my picture down if you would, because I don't like to have to look at myself. My goal really is to share the story that my wife and I, the journey that we shared for 12 years. My wife, Jerry, was a nurse who received her master's in public health at Columbia University and subsequently ended up as the CEO of the largest long-term care facility in New York City called Beth Abraham. I know nothing about a clinical diagnosis or experience. I just ensured that I married nurses along the way. And I think one of the things that Jerry and I like to share is we do not subscribe to the frequently held belief that Alzheimer's is a terrible disease. We believe that Alzheimer's is a difficult disease, especially in the late stage, but there are many, many years in which it can be a very rewarding journey if that is the choice of the person living with the disease and the care partner. So as we spoke to many people across the country and occasionally in Europe, we always asked people to look at their situation and choose to see what the positive side of living with this disease could be. And with that attitude, Jerry and I believe, had a remarkable experience with the disease. Some of the other panelists you'll hear from, Jay Reinstein is a close friend of mine, was a close friend of Jerry's, and it's by personifying what someone living with a disease can represent, to being in front of thousands of people, being present, showing that there is an attitude that is hopeful. When Jerry was diagnosed in 2012, there wasn't a great deal of hope in the community. Monica just described a wonderful new program called GUIDE. There have been breakthroughs in research that are astonishing, that we would never have anticipated in 2012, that in Jerry's tenure, in my lifetime, we would have the opportunity to have a much simpler diagnosis with a simple blood test, that we would have disease-modifying treatments that slow the progression of the disease and give the patient added time in the early stage of the disease when we are most cogent and when we have the greatest opportunity to enjoy those benefits. This is tremendously hopeful for our Alzheimer's community. But one of the things we need to do is be sure that the patient community, the caregiving community, is aware of what these opportunities are, is aware of the great progress we're making. Sue and I were in San Diego last week at a conference called CTAD, Clinical Trials Alzheimer's Disease, and the progress is so continuous. When I started with Jerry attending these conferences 10 years ago, wasn't a very hopeful. It was if that succeeds. Now the attitude is much more one of when we can add an additional type of treatment so that we begin to have combination treatments like we experienced in the progressive treatment of HIV. So the advent of simpler testing, diagnosis with blood tests, and with treatment now is really remarkable. One thing I did not do well as a care partner and regret is that I did not anticipate a time when Jerry would begin to enter the late moderate stage or the later stage of the disease, which is a time when many, many patients experience what is often called late stage symptoms or sundowning. She became delusional. She became agitated and aggressive. That was very atypical of her because we had such a good relationship. We had such a partnership in our advocacy. Whenever we'd speak, Jerry would speak for 5 minutes and I would speak for 5 minutes, and we'd kind of go back and forth with ping pong, trying to make fun of each other, trying to encourage people to see that there was a good side, there could be a good side to life with a chronic disease. But that, after maybe 8 to 10 years with Jerry, began to fade. The more difficult late stage symptoms became more and more apparent, and it was sometimes very difficult to be with her. She would hear children outside who were calling her name and that she needed to go out and assist. She was convinced that I had a girlfriend in the house, and she would see this girlfriend because she'd look in the mirror. So she was very sure that that person was there. So these are kind of the agitation, delusional symptoms that I wished I had been more prepared for. And one of my goals now is to help people better understand that many, many, if not a majority of patients in the later stages of the disease will experience this type of behavior. It is not the individual themselves as you knew them. It is the progression of the disease. And what we need to be aware of is that there are treatments, there are strategies to deal with this type of behavior, and it's our responsibility. Knowledge is such an antidote to fear. I was afraid. I didn't know. Had not educated myself, which is embarrassing as an advocate to say, but I had not wanted to look ahead because I did not want to know what life would be like in the late stage, and that was a mistake on my part. I know now that there are strategies. I know now that there are new breakthrough medications, symptomatic treatments for Alzheimer's. We're having some challenges with some of the regulatory environments that are still that need to be changed, but we're making great progress. And toward the last 8 months of Jerry's life, she was in a care facility, a memory care unit. And I tried very much to get that organization to use these new drugs that I was hearing about, designed specifically for aggression and for agitation and for delusions. But there is a resistance within the community because the regulations made it difficult and for facilities to use and try and implement these new drugs. So part of our fight in the community is to be sure that these new treatments are understood as thoroughly and quickly as possible, and it's up to us to push. We need to make ourselves responsible and aggressive in enabling patients and their care partners to be able to take advantage of the great breakthroughs in treatment. So I always like each of us to kind of look at, well, what more could I be doing? As a patient, we have a tremendous voice. I have been astonishing since with Jerry being co-founders of the Voice of Alzheimer's, the voice of the patient. We really can make an impact. And I encourage everyone to use their voice. Sue, thank you for letting me speak. I love working with the wonderful folks you've recruited today to be part of this program, and look forward to our collaboration in the future.
Thank you, Jim. Thank you so much for telling your story, Jerry's story. It's a powerful perspective. People need to hear it. Our next speaker is Amy Stewart, Chief Nursing Officer for the American Association of Post-Acute Care Nursing, or APACN. Amy has more than 28 years of experience, is a master teacher for a variety of APACN's programs, and is a nationally recognized speaker and subject matter expert on a variety of post-acute care topics. Welcome, Amy.
Thank you, Sue. And thank you, Jim, for setting me up for success here, because I am a nurse and I have worked with patients with dementia for a number of years. And before I get into my story as a clinician, I would like to share, I believe you have a couple of slides for me. The next slide, please. I'd like to share a little bit of my story with you. So my father, I'm not only a nurse, and I've been a nurse for 28 years, but I am the daughter of a parent who had Alzheimer's in the pre-2012 era that Jim spoke about. So the resources that you've heard today were very, very limited. But one thing I know that I want people to know is before my dad was an Alzheimer's patient, he was the boyfriend to my mother, and you see him there in his National Guard uniform. Then he was a husband to my mother. Next slide. And yes, this is me. He was a father to 4 children. And at this point, of course, I cut my siblings out, and I was the youngest by many years. And he was a great father, a great provider, and a very, very, very wonderful human who just instilled so much work ethic in us. And next slide. And he was very supportive. This is me on the day in 1997 when I graduated from nursing school, and he was there with me. And he was very proud. And in that picture, he looks way more proud than my mother does. And so I love this picture. And I'm sharing this story because I was the first person to notice that there was something going on with my father. I was in between houses. I had sold my house. I was buying a new house and I was staying with them. And I noticed right away something was way off. And I knew this because I had been a caregiver and a nurse of dementia patients and Alzheimer's patients for many, many years at this point. And I saw what was coming, and my mother refused to admit that there was anything wrong. So for the first few years, we just ignored it because my mom didn't want to address the fact that there was something going on with my dad and that he was changing. But inevitably, we came to a point where we needed to address this. And I'm going to fast forward a bit. My mom took care of him for 10 years at home. He had agitation, anxiety. He would wander. He would get out of the house. It wasn't safe, and my mother was running herself ragged. And many times we'd approach my mom and say, it's time that, Dad's in the late stages of Alzheimer's. We need to get him some help. But I also knew what he was going to be facing in the nursing home. Jim mentioned some of the regulatory requirements that limit some of the treatment in nursing homes. And that's really what I want to address. Many of you are caregivers on here. And I want to share what I did on behalf of my dad. My dad was the patient, and we in long-term care, which is where I've worked all of my nursing career, we have a right. We have an opportunity to provide person-centered care. And that means that advocates, caregivers need to advocate, for that person-centered care. So eventually my mom did decide to put my dad into a nursing home. The first nursing home, he was there 24 hours and they were very poorly equipped to handle his behavior. He actually hit a CNA, was sent out to the hospital, and the nursing home refused to take him back. But fortunately, this was actually a godsend because the next nursing home he went to worked with us very closely. And he was able to get the most amazing care there. They understood what his behaviors meant. For example, he hated a chair that was in his room. It was a chair that he fell out of, and he was afraid if anyone else sat in that chair that they would fall too. So he was acting out on their behalf, but he couldn't verbalize this the way that you or I could verbalize, don't sit in that chair, you could fall out. The nursing home, of course, had to meet those regulatory requirements by decreasing his medications. And every single time they would do that, he would go out and he would have a hospitalization where they would reintroduce the medication. And this is not uncommon, but the last time this happened, I worked with a physician, and I encourage you as caregivers or professionals to advocate on behalf of the patient and say, this isn't working. He would get so agitated when they would take him out of the nursing home and put him into a new environment. And that's not healthy. It's not helping him. It certainly wasn't providing him the quality of life that we intended for him in his final days. With a lot of working with the nursing home and the caregivers and in the nursing home, he was able to finally stop the gradual dose reductions, which are a requirement. He was able to stay on his meds. He was able to get the meds. And he was able to actually die in that nursing home with these caregivers that he had had for years. And we are so grateful for them. But if there's one thing I want you to walk away with today, it is that you are the best advocate for your patient or your loved one. And don't stop, even though they're going to tell you some stories about this is what we have to do, this is what we must do. It's okay to continue to push and continue to advocate and to continue to work with the physicians to get the treatment that is best suited. It's person-centered care, not facility-centered care. I'm happy to share my story with you today because I think it will make a difference. It made a difference for my father, and I know that it can make a difference for you as a caregiver or you as a professional caring for an individual that has these symptoms. Thank you. Sue, back to you.
Amy, thank you so much. Thank you for sharing your story. Thank you for doing everything that you do every day. And just really want to reiterate what you said about making sure you advocate and work with your clinician. Our third speaker is Jay Reinstein, who is an esteemed patient advocate and board member of the Alliance for Aging Research. Jay served in local government, working in leadership positions in several cities across North Carolina, including Durham and Fayetteville. In 2020, Jay was diagnosed with younger onset Alzheimer's disease and has since built a platform to raise awareness, develop public policy, and raise funds for Alzheimer's research. In addition to serving on the Alliance's board, he also serves on the Alzheimer's Association's National Board of Directors and was named the National Advocate of the Year for the Alzheimer's Association in 2023. Jay, welcome, and thank you so much for being here with us today.
Thank you for having me, Sue. And I will say this, the resources that I got to learn about today, I wish I would have known about these resources a number of years ago to help really navigate through the process. But, you know, for me, I was diagnosed 5 years ago. I try to live my life well and also sort of a glass half full kind of life. Try to stay positive. Positivity is really important. And I had a career that I loved in local government. I loved being a public servant. So when, after testing and everything, and I got a diagnosis of early onset Alzheimer's, I felt like I was going into this black hole because I really didn't know anything about the disease and what to expect in the future. And by getting myself involved in different organizations and getting on different boards like the Alliance and Voices of Alzheimer's, it's given me a voice, and it's really changed my life being an advocate because honestly, it's all about purpose for me. And after my career, I sort of didn't have that purpose. But with it's come a lot of other things that I've had to, you know, go through. And be honest, I try not to paint this rosy picture all the time.
Yeah.
Because while I'm staying positive, it's still difficult. And while I have those shortcomings with retaining information and short-term memory and not being able to drive, there's so many things I can do. And I think with all of this has come, you know, I guess you call it, is it NPS, neuropsychiatric symptoms? And I've experienced, you know, quite a few, you know, from the anxiety, a lot of anxiety and depression. I see a therapist. I've been on a medication called duloxetine, which really helps me. I think it's sort of, I don't know, it just takes away some of that tension, you know, that I have. And then I get, you know, sleeping is difficult. Honestly, you know, I'm a 3 or 4 hour a night sleeper. I wake up a lot. But I, you know, through it all, you know, I see a therapist. I'm in support groups. And I will say this about support groups. They have been just so important in my journey because to have conversations with people that are going through similar things as I am, it makes you feel like you're not alone. So, you know, the journey has been, you know, very interesting for me, but I still, through it all, I think just staying busy and getting plugged into different organizations. And I've said this before too, that I don't want to be involved in an organization if it's just about checking a box. With the Alliance and with Voices of Alzheimer's, I feel like I have a lot to do. And there are projects that I get involved in. And I feel like these projects are making a difference. And for me, that's what it's all about, Sue.
And you participated with us in these videos on neuropsychiatric symptoms called
did.
Expert Conversations. Those are available on our website at agingresearch.org/NPS, and we'll have all of this all together. But those are great to hear directly from people like you, from family caregivers. And I just want to mention, I really appreciate hearing your story, but just want to reiterate that, as you mentioned medication, Amy, certainly mentioned it. And we talk a lot also about non-pharmacologic approaches. There are a variety of things that folks can do and tools in the toolbox. And the most important thing, I think, is to really work with your clinicians on a strategy. And I know you mentioned going to a therapist. Who else has been really critical to your care plan?
Well, I'm fortunate, I have a daughter that lives 15 minutes away from us. She's a teacher, and my wife, who's still working full time. I had to, retire 5 years ago, but my daughter has been amazing. She's traveled with me. She calls me every morning at 6:30 in the morning on her way to school. And these connections are important, but it's between my wife and my daughter, but I'm very fortunate. So to have that core group of friends around me, to be able to call, to say, hey, let's go to a movie, let's go to a game. I don't drive, so I hate being stuck in the house. And these friends that I have, and I'm so fortunate, picking me up often during the week to take me to lunch. And it's important. And I will say this, that I found that since the diagnosis, when I am home and I'm thinking about things, I get very anxious. I worry about the future. But when I'm out and about and I have things to look forward to, like my travel, like going to a museum, my wife and I going to, we love to go to the movies. Those things are really important. And I also don't want to be Jay, the Alzheimer's guy. I don't want that identity. While it is a part of me, there's so many more things that I have to offer and that I can give. And I think that while I worry about my future, one thing that we talk about these new therapies that can slow down the progression. Because I'm on blood thinners and I have several autoimmune issues, right now, I can't get on one of these drug therapies. But I'm on rivastigmine, I'm on memantine. I see a neurologist regularly. I'm in a program at Georgetown where they monitor my my brain. I do have a brain still. But it's about, to me, it's about positivity and not being isolated, and giving people hope, because it's not over. And while I'm slowing down a little bit, Sue, I just feel like if I can be an inspiration, if I can convey to folks that support groups are important, staying active, diet's important, exercise, and just being out there. Those are things, and those are the tools that I want to give to people.
That's great. I love it. And I think what you offer in addition to hope is authenticity, and so does Jim and so does Amy. And I want to invite all the speakers who have joined us so far from the first two panels. So if you're able to, no pressure, but if you're able to, please put your cameras on. If we have a couple of questions, I just wanted to give a little bit of time for some open questions. And one that I had, Dr. Clevenger, was, Jim spoke about his experience with Jerry and how her agitation became evident sort of later on in her disease. And I'm just wondering, is that the way it happens for everyone, or just sometimes these symptoms, do they occur earlier? Can they even occur prior to maybe noticing memory problems? And Monica, if you have anything you want to add to that after Dr. Clevenger goes, or Amy, it'd be great to hear from the three of you.
So first of all, I have to say everyone experiences their symptoms in their own individual way. And so we sort of have to make space and have an open mind when the person or people around them are sharing these symptoms or concerns, that it can occur honestly at any time. Now, if I were going to draw sort of a bell curve of frequency and when things seem to peak, it's going to be different by the pathology. So the disease that's underlying these dementia symptoms. Alzheimer's is still today, so we have more biomarker tests, the most common cause. And in that condition, I would say we really do see that peak in that middle stage. So we would say maybe 5 years or so, 3 to 5 years after we've had some apparent symptoms that have been cognitive symptoms that are significant enough, they impact our day-to-day independence. So that's middle stage, but for someone who's living with Lewy body disease much earlier, frontotemporal disease much earlier, and absolutely, it may precede other cognitive symptoms for all kinds of reasons, both like the way that your brain is wired, the way that it's become wired over time with your experiences, and also other changes in your health, and so, but one last thing I'll say, and I know there are others who can answer this from their perspectives as well, is that sometimes it is the first symptom, these neuropsychiatric symptoms, that drives people to care or to a different kind of care. And so there are many people who arrive in our quote unquote memory clinic, kind of misnamed, because of their neuropsychiatric symptoms. It's the thing that really drives people to a specialist.
Thank you. Any others?
Yeah, I would just reiterate, in my experience in talking with families, sometimes changes in behavior significant that are very unusual for that person is really what has triggered or driven that person to see a clinician. But I've talked to a wife, she was going to divorce her husband because she thought he was just being a jerk. And, then when they went to see the doctor and realized that he had a diagnosis of dementia, then everything made sense, right? And so, but that's kind of typically in those situations, the stories that I hear, that there was just a significant change in a normal behavior of someone that they've known their whole life and been married to, and all of a sudden it just doesn't make sense. And that's what kind of triggered them to do some further investigation.
So I would just add that, I got to the point where I was afraid of Jerry when she would become delusional, because I was afraid I would hurt her or she would hurt me, and it was unsafe. So we were blessed that we could afford to put Jerry in a memory care, a care facility. And I just reflect on, my goodness, millions of Americans are not able to afford that stage care. And how do they manage these patients? We need to have the strategies and the much more readily available symptomatic treatments that help folks who cannot afford to establish a relationship with the memory care unit.
Sure. And I think just even dialogue and breaking through the stigma and education to make sure that people understand these are incredibly common, to be able to recognize them in the way that when we think of Alzheimer's or other types of similar diseases, that it's not, only memory loss. That's typically, I think, what people think of. Anybody else on that? That's such I think, an important question. Someone asks here, oh, go ahead.
No, go ahead, Sue.
I was just going to say, someone is asking here, I think, a really good, poignant question, which is, how do you approach a loved one that seems to be experiencing some issues to convince them to get help?
I would love to take this, because I lived with, not only from being a nurse and working with families, but my mother for years really thought that my dad was making up his symptoms. And so, I think it is hard to get someone to get the help who doesn't want to get the help. But you can work with your physician to get, to kind of say, hey, this is where I'm at. Can you help me to get through to this person? Or in the early stages, I will say, like in my own personal experience, we could talk to my dad and say, does this seem like something you would do? Early stage. Late stage, I always met him where he was at. If I was my sister, I was my sister. But I'm talking about, that early stage when he could still say, okay, no, this doesn't really seem like something I would have done. And, we would talk to him, like, why do you think you're doing this? Again, early stage, I want to make sure the caregivers know that on this call or on this webinar, because the late stages, my mom was still trying to do that. And all it did was drive the agitation more. So I think, my dad would really reflect a lot on that. Like, this isn't something I would have done before. So why am I doing it? And we also would say to him, what if this is like metabolic in nature? Again, he knew I was a nurse for a very, very long time. So he would definitely listen more to me as a nurse. But again, just like, we have to rule out everything, and I'll let others weigh in as well.
I think, Amy, that's an excellent point, and that sometimes there are other things that can mimic dementia, but can actually be treated, whether it's depression, it could be a thyroid issue, it could be a reaction to medication changes. And so maybe using that as an approach to get someone to see the doctor, because those are things that can be treated. And then I would just mention, for those over 65, you're entitled to an annual wellness visit, and ask the doctor to provide cognitive screening as part of that annual wellness visit. To your point, it just makes it seem like it's part of the process of seeing the doctor for that wellness visit. And so it doesn't seem like they're just isolating that specific issue when addressing any concerns.
And the other thing I would add to Monica's great points is, there's other things that can cause what appear to be neuropsychiatric symptoms. So if you are uncomfortable or, experiencing pain or, not able to communicate that you're not so happy about your schedule being changed up on you. There are things that can be that are worth trying first, often, times, and really important to try first, before necessarily going to the place of saying this person is experiencing XYZ for sure. But that's why it's so important to talk to your clinicians and have that ongoing dialogue. Dr. Clevenger, did you want to add to that? No, you're good. Anyone else that I missed?
So
Go ahead, Jim.
I would just add that I think flexibility for care partners is so continually important. While Jerry and I had always strategized on treatment and our activities and our advocacy through the early and moderate stages of the disease, as the later stage came, and I wanted to talk to her about these symptoms she was of aggression, of anxiety, of delusions she was experiencing, just for I was wrong. And whenever I would bring them up, she could deny that was any part of her possible behavior. So I had to learn, and it was very difficult to let go of the partnership in this disease that we had had since day one. So I think that we need to be able to move forward and accept that the patient is changing, and that sometimes it is not the best thing to discuss with them, but to just move ahead as we think is best course.
Okay, great. I know that we had a question, Bonnie. I'm not sure if you're answering this live, but in a way that other folks can see. But I know someone mentioned that they were having a challenge getting an appointment for their loved one that wasn't going to happen with a neurologist until next April. And then I think they weren't getting, a diagnosis or any type of testing done until even next fall. So if you're on and you want to answer that live, it might be helpful for several people who are listening in today.
Hi, Sue. Yeah, I was managing the question, the Q&A, but I'll take a stab at it. One, this is, I hear this all the time. I've experienced this certainly with my own father. The wait lists are incredibly long. I'm sure Monica knows all of the stats around that. There is a telehealth neurologist company called Synapticure that is aiming to reduce wait times to 2 weeks. And so that's where I would start. And again, it's neurologists, a network of neurologists for all neurocognitive diseases. So hopefully that can be of some assistance.
Yeah,
I
there
would
was a question about whether or not that telehealth, what do you do in cases where telehealth might be a challenge? Is there another way to communicate other than through telehealth?
so I would just say, in reference to guide, because I think that question was asked around that, people like to have flexibility and choice, and telehealth is just one method of being able to get support. And so there are, specifically to guide, there are guide participants that are brick and mortar, and you actually drive there and you go and you meet with the team. And so I think it's just a matter of knowing who are the guide participants in your community. I know Synopticare does provide guide services as well. So after getting that diagnosis, you can, if you have traditional Medicare, you can move right into the navigation service that's covered under Medicare. But really becoming, I think, knowledgeable and educated about what resources are available in your community, especially as it pertains to guide, because many of these guide participants can do detection and diagnosis and help relieve some of that backlog that's happening in the health systems to get a diagnosis sooner, especially with treatments, because we know that those are really targeted to those in the very early stage of the disease.
Okay, thank you. I'm going to shift to our final panel unless anyone has a burning extra comment that they want to make from our panelists.
I just want to add that many states that I've worked with do have statewide memory clinic networks, and it may not be with a neurologist. You may be seeing a geriatrician, a geriatric psychiatrist. Most people in this country are not diagnosed by neurologists. It happens in primary care. Fresh guidelines are out to help our primary care clinicians to follow a standardized process. But don't feel like you have to find neurology. And so I would look for your state. Memory clinic network is typically how I've found them in many places across the country.
Thank you, Dr. Clevenger. And Monica, I'm happy to share what you put with everybody here so that we get that out there. Monica mentioned also the incredible folks at the 24/7 Alzheimer's Association helpline, and the numbers up here for everybody to take a look at. All right, well, we're going to move on to our third and final. And for our next panel, From Insight to Impact, Driving Change in NPS Care, I'm going to be joined by Chad Worst to discuss the efforts of Project PAUSE, which stand for Psychoactive Appropriate Use for Safety and Effectiveness. And Chad and I co-lead this multi-stakeholder coalition of national patient advocacy groups, clinicians, researchers, long-term care providers, and professional organizations who are all dedicated to promoting evidence-based, person-centered treatment for neuropsychiatric symptoms. And we primarily focus in long-term care settings and in particular nursing homes. And we look at barriers, access barriers. While I share more about Chad, please feel free to complete the last two poll questions of the webinar. Take a look at those. And Chad, for folks who have not had the pleasure of meeting him yet, serves as Chief Executive of the American Society of Consultant Pharmacists, ASCP, and he is a board-certified geriatric pharmacist. Chad established a nationwide geriatric-based pharmacist consulting company to educate and provide medication management services to nursing facility residents and administration, long-term care pharmacies, and the public, and he presents nationally on medication management. Chad, thank you so much for joining me. And the first question I'm going to ask you is, can you tell everybody here who might not be familiar, what is a consultant pharmacist?
It's a great question. First, thanks for having me, Sue. Always a pleasure to work on these issues alongside the Alliance for Aging Research and our other partners. Consultant pharmacist it's an old term. ASCP has been around since the late 60s, established in 1969. And in those days, a consultant pharmacist would have been identified as a pharmacy, a community pharmacy that was consulted by these newly formed nursing homes that were coming online in the late 60s about how do we handle medications in this sort of institutionalized, home-based system that was really developed out of the Social Security Act of 1965. So the original consultant pharmacist was just that. Let's ask the local pharmacist and pharmacy, how do we get medications to people that now live in these nursing homes? Over that 56 years until today, our industry and our pharmacists and pharmacies have evolved really on two planes. One is how do we store, handle, deliver, help with teaching about the administration of medications in nursing facilities, assisted living facilities, and now into the community setting. But we also have evolved along the lines clinically of, well, how do we make sure that somebody that's on 8, 10, 12 medications are having those medications managed well? Are they on the right medications? Are they on too many medications? So consultant pharmacists today sort of are between those sectors. They're consulting people on what's the best way to get my medication. Do I want a pouch packet? Do I want sort of the traditional amber vials? Do I want it delivered? And then consultant pharmacists spend a lot of time, particularly in nursing homes and assisted living, going over the medication regimens of the people that live there, trying to make sure that the regimens that they're on are safe and effective, and that they're not having any problems with those medications. And, arguably, they're not overprescribed things. So that's what a consultant pharmacist does today.
Excellent. Well, a new policy study from a consulting firm here in Washington, D.C. called Manat Health found that neuropsychiatric symptoms in long-stay nursing home settings are often misdiagnosed and not necessarily well treated. How does this misunderstanding of neuropsychiatric symptoms affect residents' access to safe and effective care, would you say?
I think first of all, and I think everybody that's been on today has talked at some level about the complexity of these conditions. These are difficult, serious mental health issues at times, behavioral issues at times. Neuropsychiatric symptoms can be very difficult to pin down in terms of what's causing them. And I think when you work in the nursing home setting in particular, you work with older adults in general, you're now, I think, used to this idea that, okay, they're presenting with some memory issues, or they're confused. There's a litany of things we have to do once we identify that before we get to what's the solution. I think maybe in the past, there was some knee-jerk reactions to using medications and other therapies quickly without really getting to the bottom line of what issue it is. Is it Alzheimer's dementia? Is it a urinary tract infection? Is it something else that the person's taking from a medication perspective that might be influencing the symptoms? So I think at face value, it's very complex. I think we've gotten a lot better. Our care for older adults is a lot better. We know more about different diseases. Again, some of the people that have been on prior to me have talked very specifically about the conditions that affect them and what kinds of things they've done to be successful at managing their condition. And we're doing that in nursing homes. I think the challenge is that sometimes we're directed, to follow some maybe older stigmatized philosophies around medications, and that's created barriers. I mean, our whole healthcare system, we could talk on a whole different topic about how we have kind of a system of denial and kind of holding back different options for patients. But in reality, when we're faced with people with neuropsychiatric conditions and symptoms in nursing facilities, we have to be very open to what it is that's causing it and what the options are to treat it. This is not like treating a condition like blood pressure or cholesterol, where you have a very specific target and you have a very specific drug. It does involve the art form of treating people and really getting their symptoms and their behaviors, if that's what's occurring in them, under control. And you have to have the ability. I usually talk about the crayon box, but we have to have the crayon box of 64 crayons because everybody's a little different and their condition is a little bit different. So it involves quite a variety of approaches, from non-pharmacologic approaches to pharmacologic approaches at times, and if necessary. And as clinicians, we have to have the ability to pick precisely the color that meets the need of the individual that we're treating. And a lot of our healthcare system, whether it's the insurance payers or whether it's some of the ways we've crafted quality metrics from Health and Human Services and CMS in particular, create closed doors and barriers to getting to the right color crayon that we need for that particular person.
Yeah, I love this. I love that analogy. Um, So you and I, together with a bunch of other provider organizations, family caregiver, and resident and patient and older adult groups, all work together in Project Pause on something called the long stay antipsychotic medication quality measure, which is a quality measure that was developed by the Centers for Medicare and Medicaid Services, the federal agency that runs the Medicare and Medicaid programs. And this quality measure was a well-intended policy that was designed to curb inappropriate antipsychotic use, but it has caused some unintended barriers to treatment for more than 3 million residents who live with Alzheimer's and related diseases. Chad, can you just give a brief sort of overview of the measure and the major issues with it?
Absolutely. And I think it stems back to the first question. About half of the history of ASCP ago, in the late 70s and early 80s, we didn't have very targeted medications. We had very broad antipsychotic medications, and they were used pretty aggressively in nursing homes, and they were probably used inappropriately, more than likely because we didn't know what else to do at that time, and these were the available options that we had. And that ultimately led to a quality measure from CMS that speaks to whether or not somebody's on an antipsychotic medication, a specific class of drugs, or not. So the current long stay metric that was developed over 12 years ago was a measure by nursing facility of how many people are on an antipsychotic divided by how many people are in that nursing home. So a very simple measure, probably a little too rudimentary of a measure, but a simple measure that just gives you a percentage of people in the nursing home that are on an antipsychotic. Again, as you mentioned, 12 years ago, somewhat well-intended. We wanted to make sure that if somebody's on an antipsychotic, that we're looking to make sure they have the right diagnosis, that we're following the efficacy of the medication, that we're following the safety, the potential risks of the medication on the individual. But at the end of the day, it doesn't really give us a lot of context to whether or not it's correct or not. It's just telling us that it's there. Over that 12-year period, CMS has been very aggressive to use that quality metric to define quality for the nursing home and to the public on their Nursing Home Compare website. And they kind of rank and compare nursing facility to nursing facility based on that percentage number. The downside of that is that it really doesn't give you any insight into whether or not those medications are being used appropriately for the individual or in that particular nursing facility. So from the perception of the public, it's an interesting number to know, but it doesn't tell you if they're doing a good job or not. That nursing home in particular with a 20% antipsychotic rate might be a specialized nursing home that is focused on patients that have neuropsychiatric conditions, and therefore you would expect might have a higher percentage of use of those medications. And it could be very appropriate at 20%. It could be under appropriate, to be perfectly honest. Just the idea that that number doesn't really give you context. You could see another nursing facility that had a very low percentage of 5%. And that nursing facility might also not really give you, that number may not give you any insight into whether or not they're good at managing psychiatric conditions with antipsychotics or not. It also created a lot of aberrant behavior in the nursing home industry where if the drug wasn't an antipsychotic, then it obviously didn't count in that quality metric. So you saw a lot of use of anti-epileptics, which are drugs for seizure disorder that were taking the place of an antipsychotic, but still a very dangerous medication with limited evidence to whether or not it could really provide benefit to individuals, but ultimately it didn't count. So we saw people using more benzodiazepines, anticonvulsants, anti-epileptic medications versus antipsychotics. So now that measure even becomes more blurry as to whether or not it's providing good context to how medications are being used. It also created quite a bit of stigma around people that had serious mental health issues that were treated with antipsychotics, and the idea that if they were admitted to the nursing home, that they would come in and they would negatively impact the quality score of that nursing home simply because they were being managed with an antipsychotic. So we've really taken an approach that we want to see a quality measure that really does give context to the public, that can tell them whether or not a nursing home is doing a good job managing neuropsychiatric conditions and symptoms. We know that that's going to continue to grow in that population as people age longer and healthier. These kinds of conditions are the ones that go along with an aging population. So we have to be better at being able to articulate, are individuals appropriately identified with psychiatric conditions? Are they appropriately treated with psychiatric conditions? And we need a measurement that's really reflective of what does the prescriber that wrote this prescription think about the utility of this medication for this patient? What does that consultant pharmacist that's reviewing those medications on a monthly basis, what do they think about whether this medication is providing benefits or has any potential risks? And how does that help define whether somebody's on the right medication? And that's what we're really pushing for with Project Pause, is to give that context through that measure. If we're going to have a measure, it should be providing good information about quality care. And currently, the measure we have doesn't really do that.
Thank you. That's terrific. And I think it gives a really clear picture of what we're trying to accomplish and what's going on from a public policy standpoint. So we really appreciate everybody being here today on our panel. I'm going to ask panelists to put their cameras on again. I have one more question for all of you before we wrap up today, and I get to thank you to your beautiful faces. My last question is, how can we promote more patient-centered approaches to Alzheimer's care to help address neuropsychiatric symptoms and, also sort of any kind of inappropriate approaches that are used? And this is really for anybody.
I would
just say evidence-based care, that there's great evidence out there. There's tools and resources that are based on, an international criteria that walk providers through non-pharmacological interventions, and then when appropriate pharmacological treatment. And I think that that's important, that evidence should drive care, not opinion or quality metrics.
Thank you, Jen.
I think we have
Jason?
No, go ahead, Jim.
I think we have a huge job just educating the caretaking community and the general public further. I mean, the stigma of Alzheimer's on top of the late stage symptoms make it extremely difficult, period. And the more that Sue, that you and Pause has been able to do to begin the education process, and that we can carry that forward as a community, is really extremely helpful.
And Jim said it better
Jason?
than me. Jim said it better than me. I would say, one key piece of advice is to formally engage and value the family caregiver's contribution to care. To be more patient-centered, you must be more caregiver engaged and caregiver centered, particularly as it relates to the conditions that we've all been talking about today.
Excellent final comment. All right. Well, that's all the time we have for today. It's been an extremely valuable discussion. I thank all of our panelists for joining us and all of the folks who joined us on this incredibly informative webinar for coming today and for your thoughtful questions. A special thank you for Otsuka and Lundbeck for the support which made this possible. You can find the resources discussed today and more again at agingresearch.org/NPS. We're going to post a recording of this webinar soon. Thank you all so much and hope you have a wonderful afternoon. Bye-bye.